So my topic is a very important topic whenever we venture in doing osteotomies. Believe me, if you have started your osteotomy and this hinge fracture, you are going to have this. I once talked with Christian Clay, one of the giant of osteotomy. I told him, see, I have been getting hinge fracture a lot. He said, oh, you are also getting. I'm very happy. I also used to get. So I think everybody gets this. This is one of the learning curve. And once you get these complications and you learn from these cases what wrong you did in those cases, and you learn from that cases and you do not do it again. So let's start. So in life, sometimes small changes makes a big change. Small things make a big change. It's just the same in hinge. In osteotomy, whether it is distal femoral osteotomy or high tibial osteotomy, there is that lateral hinge, almost about 1 centimeter of lateral hinge, that makes your surgery, whether it has to go into success or it's a failure. Because if you have intact hinge, everything goes picture perfect. In today's osteotomy pre-conference also, we say we preserve that one almost 5 millimeter of hinge, and everybody has seen it was very stable. So if that hinge is not there, there is all sort of complication. There may be delayed union, you have to delay your weight bearing, there may be even non-union, etc., etc. So this small thing is very important. So hinge point, where should be the hinge point and why that particular point is important? Hinge is important for healing. It's very important for healing, because as we all know from our general orthopedic knowledge, for healing you need to have biology, you need to have stability. Once hinge is gone, there is no stability. Stability is grandly compromised. So hinge should be protected. Why that particular point for hinge? Actually, it falls right at the cora region. But it's not at the cora region. The cora is way more medial than the hinge point where we put during our osteotomy procedure. But the particular position is taken because it is near the proximal tibiofibular joint, and there are many ligaments, many soft tissue structures, PLCs and all are attached over there, and it is very inherently stable structure. That's why even if you make some type of like type 1 hinge fracture, it's still stable. That's why that hinge point right at the top of the fibula or at the little lower to the top of the fibula is very, very important. You must have that thing during your surgery. Osteotomy had bad name because osteotomy started way before the total knee replacement, and it started, pioneers were Jackson and Vogue. There was Coventry started closing wedge osteotomy. He didn't have that good implants, so the scanogram was not there. It was not so much technical. That's why the osteotomy had bad name, and suddenly there was source of total knee replacement, and companies were also promoting these prostheses. That's why there was somewhat the osteotomy, high tibial osteotomy was in a state of hibernation until these guys like Purdue and the AO guys came along with some angle stable plate, and then there was resurgence of this osteotomy. Nowadays, this is the first two pictures are the Purdue plate, second is angle stable plate by AO. So let us talk about the lateral cortical hinge fracture. Takeuchi in 2012, he described 3 types of hinge fracture: type 1, type 2, and type 3. Type 1 means when the hinge fracture, the cord extends right up to the lateral cortex, then it is type 1 hinge fracture. Type 2 means when the fracture goes down towards the metaphysis, that is type 2. And always in general orthopedics also, whenever joint is involved, it is bad. That means it is always type 3. So type 3 is when joint is involved, that is type 3. So this is the principle of osteotomy. This is where we take a hinge point and cut. This is how we open. We make the alignment right, and we put the plate. When hinge fracture occurs, let us zoom it. So this is type 1. When it goes through and through, that is type 1. Type 2 means when it goes through the metaphysis. Type 3 means when it goes up. So this is most complicated one because joint is involved. What happens, what to do when there is type 1 fracture? Usually type 1 fracture is considered as the stable ones. many cases, the beauty of this tomofix plate, beauty of this angle stable AO plate is there is oblong hole where there is a place to put the cortical screw, that is not non-locking hole is there. And if you put that screw, that is called golden screw, if you put that screw, there will be hinge compression. Even in normal osteotomy condition, when you put that screw, you will feel your osteotomy opening being slightly reduced because of that compression. So type 1 will be well taken care of by the plate only. And sometimes these cases are not so obvious, and even post-operative rehab can be delayed, the weight bearing can be delayed, and usually these are usually on-demand. Type 2, they are very unstable. This occurs because if we put the hinge position, that is hinge position way too inferior, and you open it, it is the result of that thing. And when there is type 2 fracture, what happens? The proximal fragment and the fibula becomes a separate fragment, and distal fragment becomes separate fragment. There will be some rotational instability. That is why this is considered unstable one. If you detect it after surgery, it's not rare condition, because even after surgery, if you do, it is detected way more commonly after surgery. And if you detect after surgery, you can delay weight bearing up to about 6 weeks and start weight bearing only after callus formation. If you detect on table, look for stability. If you are not okay, if you are not convinced, better to open the lateral side and put some plate. So this is how we should fix this. Type 3, this is just like tibial plate to fracture, lateral tibial plate to fracture. You have to fix it. Joint has to be made congruent, fix with that, and then tomofix plate. All of these type of fractures, if they are not so much displaced, tomofix, the golden screw, will take care of many of this because of compression. So first attempt is reduce and put that screw, many hinge fracture will be compressed. So hinge fracture consequence, why we are so worried about hinge fracture? The stable construct becomes unstable because of instability. Because of unstable construct, there may be loss of correction. You corrected 10 millimeter, you corrected this much degree, and at the end of surgery, the correction is not as you have expected. There may be delayed union or non-union. Even the slope change might occur. So where is appropriate hinge position? This is the paper. I forgot. I think this is paper from Nakamura, and he gave this concept. During osteotomy, when you put that guide K wire right directing towards the tip of the fibula, you just internally rotate the leg so that this vision, this proximal tibiofibular joint will be seen in profile, and they have divided this into above medial, above lateral, within median, within joint line, medial, within joint line, lateral, and below. So right place is to put right at this area within median, and this is the safe area. And if you put your osteotomy hinge point right at this level, you are usually safe. So this is how we can see during the surgery. That is the same picture. And if your hinge is intact, usually this, you can open and close this thing, and it does not displace. If the hinge is gone, it will rather translate rather than opening and closing. So these are various positions that they have explained, and usually that match with the safe position described by this paper. This is the same thing which I have described earlier. The golden screw, the A, B, C, D, and lowermost screw. The first screw at the shaft, this is very important. This leads to the hinge compression. One thing we have to be very careful is position of fibula. All knees are not same. If the fibula is, see, this is also knee, and second is also osteotomy. In first part, the tip of the fibula is way above, near to the joint line. In second, it is way down. So the first case is the one where you should not target at the top of the fibular head. Otherwise, you may have complication. If you have some form of hinge fracture, you are doomed. So in these cases, it's good to direct somewhat inferiorly than tip of fibula, but this is not the case in other cases. So they say prevention is better than care. Why this happens is if you try to make large cut, like more than 11 millimeter cut, there is chance of hinge fracture. You should do it slowly. The opening should be slow. If you do it very rapid, the hinge fracture is bound to happen. Let the bone relax your opening. Complete cut of anterior and posterior cortex should be confirmed. Otherwise, there is every chance of cutting, making hinge fracture. premature attempt at opening the osteotomy. Make sure that only 5 to 10 millimeter lateral cortex is intact. Otherwise, if you start opening when you have 20, 25 millimeter, you are bound to make the stress has the energy has to dissipate from somewhere. So that will be dissipated from joint line, and type 3 fracture is usually because of premature opening, premature attempts to open the osteotomy. Biplane osteotomy, it prevents the hinge fracture incidence. Following the steps perfectly is only one thing. And hinge KOR, they have hinge KOR screws that is also shown, that has also shown to decrease the incidence of hinge fractures. So these are how we put the hinge fractures. And hinge fracture can be put in multiple ways, from lateral side, or from some put hinge fracture just below the joint line parallelly, so that all sort of fractures are gone. Sometimes this is again another hinge. The intactness of hinge can be checked not only with the in KOR in situ, you can see without the KOR as well. And this is how it is. So among all these three,
Vivek, 1 minute, please wrap up.
So type 1 hinge fracture is said to be very stable, and giants of osteotomy, I've talked with them, and they said that if you are not convinced about the osteotomy hinge fracture, if you are really scared of hinge fracture, do the type 1 hinge fracture, because it is very stable and it is very easy to manage type 1 rather than getting type 2 or type 3. So this is one of the cases where we had type 3 hinge fracture because of early attempt of opening. So they are very unstable. Even at 2 months, they were not stable. At 3 months, they gradually heal. And if you see the slope has increased, the correction has decreased, everything. So CT scan, I must mention this. We may think that hinge fracture has not occurred, but if you do CT scan in all those cases of osteotomy, almost 40% of them will we will see extra hinge fracture. So it's good that we should consider type 1 hinge fracture in almost all of the cases and take the measures appropriately. So this is one of the thing which I follow. If there is lateral hinge fracture intraoperative, type 1, I do not care. Type 2, type 3, I go for fixation. If it is post-operative, 6 weeks non-weight bearing, and weight bearing to be started after callus formation. So take home message, type 2 and type 3 are unstable hinge fracture. They occur because of technical error, not because of any other thing. So we have to be very careful during surgery. Most of the times, it's a result of surgical error. So prevention is better than care. Know how these occur and try to take good measures not to cause it. Thank you so much.